Choice of drug is a big part of things, and there's certainly been an approach which is like a bundled approach, and we call it the ABCDE, and recently we've added an F for family, and the C is really choice of drugs in order to meet the goals. I think it's always thinking about pain first, so starting with an analgesia. Certainly that's the way we manage our patients now at Tufts Medical Center. We always start analgesics first. We'll give some as needed sedatives. If we get a negative CPOT and we find the patient's not in pain, well then we'll start, and the patient's still agitated. Of course we'll use sedatives in some patients. But we've dropped the percentage of patients that ever receive a continuous IV sedative like midazolam, lorazepam, or propofol is really, really dropped. We've halved it over the last 5 years. So I think don't be focusing on sedatives first. Think about analgesic first. If patients do need a sedative, think about, can we just be giving it intermittently? Be very, very careful with continuous benzodiazepine use. In patients, it's a great agent for patients that are on ECMO, that have severe ARDS, where you need to deeply sedate these patients and you want them to be amnestic. But for most, for 85% of patients in most ICUs, it's really not. That's not the goal of therapy. And once you get an IV sedative going, it's hard you have to get it weaned off. And so there's always some battling that goes on in order to maintain a level of light sedation. You have to either do daily awakening or protocolized sedation. And that's a challenge. So if you never start the IV sedative and just use some boluses when patients get agitated, it's much, much easier because you haven't opened that Pandora's box. I think it's important, hypotension comes up a lot, so it's important to think about the drugs. If someone's acutely has low blood pressure, particularly if on a vasopressor like norepinephrine, about the choice of drug. I think there's, the story is not finalized with dexmedetomidine. It's certainly a drug that we do use in our ICU. We particularly use it in patients that are, we're getting close to extubating them, because its big advantage is it doesn't decrease respiratory drive. And so it keeps patients chilled out enough to get through a spontaneous breathing trial. Certainly, there is some evidence to suggest that people do have delirium and they're agitated, or help resolve delirium faster rather than use a benzodiazepine. The thing is, what we find in a lot of our patients, if they've been, say, in the ICU for 10 days, sort of our longer stay patients, and both our medical and surgical patients, is that patients will often have 3 or 4 different pain and sedation regimens. I think the other big strategy if someone's on a drip and they're starting to tolerate enteral nutrition is start really aggressively using the gut to help treat pain. So we'll use, for some of our patients on higher doses of fentanyl, which you obviously can't continue outside the ICU, we'll start these patients on methadone. There's evolving literature to suggest that it's a good strategy to get fentanyl down. You need to check the QTC. There's certainly safety concerns. And it works, differently. It doesn't just work on the mu receptor. So where you have a lot of opioid tolerance, there'll be some advantages. Certainly, if patients are on benzodiazepine, drips or requiring frequent boluses, we'll start some, lorazepam or Valium down their NG tube. And patients on dexmedetomidine, a good strategy is to aggressively use clonidine to get them off the dexmedetomidine drip. So we're always thinking, okay, the patient's getting better, we might extubate them soon. How can we get them off on all the supportive care? Because they really don't need it. I think the other thing with antipsychotics, if you do start antipsychotics for, the agitated patient, if they're hallucinating or fearful, is to have a plan to get those drugs off before they leave the ICU. There's so many patients that are going to LTACs and other places on fairly hefty doses of antipsychotics. Major safety concerns, and no one's addressing. It's really a big problem. In fact, we've actually had patients readmitted to our ICUs 2 months later, and they're still on the quetiapine dose that we discharged them on, and sort of shame on us. I mean, we should have really had a plan. If you're an academic center or a large community hospital, you're sending these patients elsewhere, and they're not going to question. They're just assuming that it's the appropriate thing, and probably the patient doesn't need it. So I think those are some of the big things, is really avoiding drips where pain first, avoiding drips where possible. Think about the plan each day, use the gut when you can, and as ICU discharge approaches, really work on reconciling what you're giving these patients and trying to peel off agents to have a much cleaner plan as they're leaving the ICU.